So the topic for today is, can metformin prevent weight gain from antipsychotics? And I am Dr. Harvinder Singh, creator of Psychiatry Education Forum Academy, as you all know. So I post these chapters for our Academy members, and this will be our 475th chapter, and I decided to make it live for everyone. And this is my first live session this way, so hopefully I'm not making any mistakes here. So you all know how important this topic is, especially for patients with serious mental illness. Patients like with schizophrenia, bipolar, they are at risk of premature mortality, right? Because of the impact on the cardiometabolic factors. And the most common factors that impact their cardiometabolic status is obesity and weight gain. And I know with serious or severe mental illness, um, their lifestyle, their underlying diagnosis, their underlying motivation, many other things play a role for that. But many of them are reversible and many of them are not. But one of the reversible causes is the medications, antipsychotics. So let's start with that. Now, before we move forward, I just want to emphasize we have Dr. Satinder Palkar with us. She's a family medicine physician, and she is also board certified in obesity medicine. So I'm thankful she decided to join today in the end. We'll see if she can answer a few questions for us based on what we are talking today. But this presentation, I will discuss in these topics. We'll discuss if metformin is beneficial for antipsychotic-induced weight gain. So friends, AIWG is antipsychotic-induced weight gain. And then we will discuss what predictors, parameters, and thresholds should inform the decision to start metformin. And does antipsychotic class really matters in your decision making? And if you're using metformin, what dose to use, how to do the monitoring, what adverse event to look for, when to avoid and when to stop metformin, and the most hot topic these days is GLP-1 agonist. When can you include them? So that will be the last one. It looks it looks big, but I will try to finish everything in less than 30 minutes. And I will most likely will not be checking my chat box right now. So I will check everything in the end. But please post your comments, thoughts, questions there. If I can, I will answer them in the end, okay? So let's start with, where did this topic even came from? So I have published in our academy updates 2 years ago, last year, regarding antipsychotics and weight gain. Mostly I go by guidelines. But just like a month ago, actually now 2 months today, December 9th, Schizophrenia Bulletin published this guideline development and consensus validation with the goal of creating guidelines to prevent antipsychotic-induced weight gain. So I have used data from this, other guidelines, and other publication, which I will mention as we move forward. Now, let's start with the basic overview. We all know that weight gain is a common in serious mental illness with treatment. And the difficulty is this weight gain is very rapid and very non-linear in trajectory. What that means is for patients with first episode psychosis here, if you give them treatment, within first year, 80% will gain significant weight gain, which is defined as 7% or more of their baseline weight. And I will talk about that in a minute, but goal of this presentation is to get some clinical pearls out of this so that you can use in your clinical practice. So the first important fact we need to keep an eye on is this 1 year and more, close to 80% can gain weight. So first year is very risky period that we need to keep an eye on when we start antipsychotics. And as you all know, we are talking about schizophrenia, bipolar, but these medications are FDA approved for MDD augmentation, also for many other indications, which we will not go into. So keep that in mind. But the other thing is, this study, published in Annal of General Psychiatry 1 year ago in January 2024, this was done in UK. It was a longitudinal study, and they looked at how the weight changes in patients with psychosis with antipsychotic treatment. And this confusing diagram on top is from this article. So this is our day 1, and this is year 5. So they actually looked at, they compared, like divided their BMI to underweight, healthy, overweight, and obese, and they looked at how that changed in 5-year period. And you can see 50% who had healthy baseline weight, this one here, friends, this light blue line, 50% with healthy baseline weight transferred into overweight or obesity, this red and light red or pink color here. That's concerning, right? Because weight gain is one of the most commonly reported side effects by patients. This actually reduces their medication compliance based on the study that was published, I believe, 1 or 2 years ago. I'm not including all the studies, but if you need reference, please post your comments on chat. I will go into that. But we should never go with just the risk. I don't want us to think that medicines are bad. They are not. It can actually change a patient's life. It can impact their symptoms, make them functional, be a part of society. Like it changes, it gives them more control. So I don't want us to get a message that medications are bad. But we have to always weigh risk and benefit, right? This is a risk, but what is the benefit? The one that I just mentioned. But the interesting thing is, and I was not amazed, but I took a pause when I read this, that despite the side effects, antipsychotics improve life expectancy in schizophrenia compared to patients who are not taking it. And anything that I say here is not just my own viewpoint. I base everything on the studies. And the study that was published in, you see, 2 years ago, December 2022 in Schizophrenia Research, they looked at factors that can reduce life expectancy in schizophrenia and improve life expectancy. Let's start with the one that reduced all-cause mortality. That means they are improving the life expectancy. You see, antipsychotic is there, antidepressant, lithium is there, and use of lipid-modifying agent is there. And very quickly, these were the factor that increases the risk of all-cause mortality. You can see most are like medical conditions like cardiovascular, liver, renal disease, diabetes, even history of switching antipsychotic, which may point toward increasing adverse event or the severity of underlying condition. And that again goes to longer duration of previous hospitalization. That means more higher dose. I should not assume, but I'm assuming that many medicines were tried or higher doses were used, which increases the risk of side effect. And obviously substance abuse and use of benzodiazepine. This is really important. You see in these two classes, when you look at medication, benzos increase mortality, and the antipsychotic, antidepressant, and lithium improved mortality. So what I'm trying to say is we need to weigh benefit and risk and make our decision. And as I just mentioned, if we are using antipsychotic, we need to manage the weight gain from that. And you can use non-pharmacological and pharmacological. It's not and or. Non-pharmacological includes diet, lifestyle. This is like, I feel this is a building block. This is like, that has to happen in addition to medications, right? But the sad news is, when I did research into that, there is a study published, I believe, 1 or 2 years ago. It's called FASTER study. Maybe look into that, PHASTER. They looked at lifestyle interventions in patients with schizophrenia, I believe, or severe mental illness. It did not pan out for metabolic improvement. So this, I'm getting a message that that alone is not enough, but I was not able to get into details of how the patient population was, what their BMI was to begin with. But this is a non-pharmacological, which we are not talking today. Pharmacologically, You can adjust the antipsychotic dose. Obviously, going for the lowest effective dose can help, but that does not apply to everyone. You can switch medication, but you all know patients who are on clozapine, that is a very difficult possibility. Nowadays, we have Cobenfy. I have not used it yet, but I'm hearing from other other doctors who have found it to be beneficial. But so far, switching is not an option for everybody. And the last is using medication, and that's where metformin comes into picture. And you will ask me, why did I even use this metformin topic, right? I could have used any other medications for antipsychotic-induced weight gain. And the reason is it will be discussed in next few slides. Now, let's start with our first question. Should metformin be used for antipsychotic-induced weight gain? And to answer this question, I will base this on the important studies that were published. Actually, there were like more slides, but I just reduced them to 3 studies here to make it easy for everyone. The most important one is the Cochrane review published 2 years ago, 2022, depending on when you're watching this video. Now, they looked at all the pharmacological interventions for prevention of weight gain in people with schizophrenia. And you all know how good Cochrane review is. And this was the result before I jump into anything. They said metformin was the only pharmacological agent that may be effective for preventing weight gain. Nothing else panned out. They actually had 17 randomized controlled trials, RCTs randomized controlled trial with a total of this many participants. And these were the medications that were compared. Metformin had the highest RCTs, 5, followed by topiramate, followed by histamine 2 antagonist, and then monoamine modulators, and then monoamine modulators plus beta histine, melatonin, and samidorphan. In our academy, we have chapters on these. I think melatonin was found to be effective close to 3 milligram per day. Samidorphan have some data, but when you looked at the Cochrane review, only metformin panned out from the statistical standpoint. So the recommendation per Cochrane review after reviewing these were, you should start metformin around the same time as an antipsychotic. This is what they recommended. But is this true? Which we will talk actually in a few more slides, when to start it. But this was the first study. And the other study, which was actually a little bit replication of that, it was a systematic review and meta-analysis. And this was published in actually 2024, last year, a few months ago in May. And they actually looked at they only looked at those studies where metformin was co-commenced at the time of antipsychotic initiation, right? This is what the Cochrane review recommended. And they actually looked at 14 RCTs, but 11 were from Chinese database, very good number of N there. And metformin group gained 3.12 kilogram less than control. 3 kilogram with the range of 4 to 2, like 2 to 4.2. And this is actually a big number. I will tell you why that is important in a few minutes, but you can see these RCTs have clozapine, olanzapine, risperidone, sulpiride. Like these are high-risk weight gaining medications, so they didn't use like those lower ones. So that was a good thing to include. And the last study I want to talk about is more large naturalistic cohort study. This was published in 2 years ago, and they looked at use of metformin for clozapine-induced weight gain. And 396 patients, and metformin patient gained 3.14 kilogram less weight in 6 months. And when they did it for 12 months, it was close to 5.38 kilogram. Now, when I read this, my mind was like, it's only 3 kilogram. Why are we making big deal of that? But when I looked at other studies, this actually impacted my thinking, which is there are like population-based cohort studies. They have found if you lose 3 to 6 kilogram of weight loss, it can prevent 42% chances of getting diabetes cases. And we know how diabetes impacts cardiometabolic factors and many other things. So that's how it panned out well for metformin. And this consensus guideline that I mentioned initially, published in Schizophrenia Bulletin, they said the first recommendation is you should add metformin at the start of antipsychotic or when you switch antipsychotic. But I will say, wait, let's not jump there. Let's not just add metformin for every antipsychotic we are adding. We need to refine that, and which I will discuss in few minutes. So we discuss our first question, that metformin can be used. Data is there. You can start it. But now, what predictors, parameters, and thresholds will inform your decision when to intervene with adding metformin? And for that, let's start with the first factor, which is the choice of antipsychotic. I want to spend some time on this one because this is the most clinically relevant fact for us who manage patients and prescribe medications. So there is genetic factors and non-genetic factors, right? In the non-genetic factors, the choice of your antipsychotic is the most important factor in predicting the risk of weight gain from antipsychotic, which many of you already know. But this is what the studies have found out. Now, this is the most important factor in decision making. Now, this is another clinical fact that we need to know. For first episode psychosis, when you're about to start medication, you should always prefer low-risk antipsychotic at the lowest effective dose. We already all know this, but it's very important to emphasize that because the second and third predictor that I will talk about has something to do with this. Now, if you have to use high-risk antipsychotic or medium-risk antipsychotic, please add the metformin early on. And I will say this also goes, I should not be partial, but for inpatient psychiatry, I see sometimes some of our patients who get admitted for bipolar first episode, many of them get started on olanzapine, which actually works faster, as you know, for sleep, anxiety, mood, even quetiapine. Those are like, olanzapine is high risk, quetiapine is mostly in the medium risk, and that's the next slide. Clozapine, olanzapine are high risk medication, quetiapine, risperidone, paliperidone are moderate risk. This is what this recent publication talked about. But what about other medication? They said everything else is lower risk. But I just want to spend a minute on that. So in our academy, I published this update last year on antipsychotics and weight gain. And we actually discussed these studies where we did dose response curve, like how certain medication have this curve. With time, the risk goes down. For some, it plateaus. For some, it goes up. We are not talking about this. I just want you to focus on this weight gain area here. Now, this is how you stratify medication risk for weight gain. And this, I believe, is the most recent publication on this topic published in Journal of Clinical Psychiatry in 2023. And I have highlighted them in colors here. So the one in blue are low-risk antipsychotics, lurasidone, haloperidol, cariprazine, brexpiprazole, and aripiprazole. And the one in orange are medium risk, like quetiapine, asenapine, risperidone, and paliperidone. And among high risk, we have olanzapine here and iloperidone. This study did not include clozapine, but we already know clozapine is there. I'm waiting to see how Cobenfy pans out with weight gain. I know that medicine does have that risk for that, or I need to check that, but let's see how that pans out. And cariprazine was not here. Oh, sorry, it's there. Sorry, cariprazine is here. So use this in your mind when I talk about low risk, medium risk, and high risk antipsychotics. Now, coming back to our slide. So the recommendation is whenever you're using a medium risk antipsychotic, like high risk, we already know you go and add metformin. But in medium risk, you only add metformin if patient have one or more cardiometabolic risk factor or their age is between 10 to 25. Very big recommendation. So that goes to the first episode psychosis, right? That's the age range where the first episode psychosis comes. And the cardiometabolic risk factors are patients with history of hypertension, dyslipidemia, diabetes, both type 1 and type 2, pre-diabetes, BMI more than 25. Now, please adjust your BMI for ethnicity because I believe in NICE guidelines, NICE, They have actually reduced the BMI to 23 for African, Chinese, and there was one more I forgot, but it should be adjusted for ethnicity to 23. Otherwise, it's 25, and obviously if age is between 10 to 25. I hope it's not confusing, so make it simple. Let's summarize everything so far in a table. So what we have learned so far is you add metformin, but it has to be based on your risk of antipsychotic. If your patient is on high risk, which should never be the first line, right? You should always go here, if possible, ideally here. But if patient is on high risk antipsychotic, you go and add metformin. Now, for the medium risk, you only add if one or more cardiometabolic risk factor is present, or if a patient is between age 10 to 25, then you add metformin. So this is our learning so far. Let's move on because we will add more to this table as we move forward. Let me check my chat very quickly. I hope I'm not missing anything. I hope everyone can hear me clearly. Perfect. Now, oops. Let's move on. So we have discussed the class of antipsychotics so far. The second important predictor and parameter is young age and antipsychotic naive patients. So three things we need to know here: younger age, first episode psychosis, and patients who are antipsychotic naive. They are all predictors of a person being susceptible to antipsychotic-induced weight gain. And these are all like proxy to each other, right? Patient who have first episode psychosis, mostly younger age. Antipsychotic naive, mostly younger age. So they all play with each other, I should say. But very, very important risk factor if you see a younger person, first episode psychosis, please be very cautious of the medication you choose. And if you can't use the lower risk one, metformin should be there. But little bit literature on that. Compared to adults, children and adolescents have 2x risk of weight gain, and they can gain actually 3 to 4-fold more weight irrespective of the antipsychotic used. And the risk factors that we use to stratify in adults, like be very mindful of the lower body mass of children and adolescents. Like there was a study, they found that they were children and adolescents who were given clozapine within a week. They gained close to 5 kilograms. Now remember what I said before, like how 3 to 6 kilogram and risk of diabetes, 5 kilogram in a week, even for adults, it's different, but for children and adolescents, where they already have lower body mass, that is a big impact on their body. And what I was saying was these predictors for adults, like baseline BMI, gender, ethnicity, they are less associated with weight gain in children and adolescents. So what I'm trying to say is, when you look at guidelines, it feels like children and adolescents are not served appropriately. The guidelines don't talk about that much. They mostly talk about, I believe, even after age 40, I believe, to have interventions. But very, very important fact here. And the key is, even 1 kilogram of weight gain increases your cardiovascular disease risk by 3.1%. So that case that I'm talking about where clozapine caused 5 kilogram weight gain, you see how much risk is increased in young age, and as it goes on, it will just add on. And the other thing that I mentioned a few minutes ago, if you can have even 3 to 6 kilogram weight loss, it can prevent 42% chances of diabetes. Now, talking from the cardiometabolic risk factor, studies have found metformin to have small to medium effect on improving total cholesterol, triglyceride, fasting glucose, and HOMA-IR, which is the insulin-resistant ratio, I believe. So it has impact on that. So good to know when you're considering this medication. Now, something to be mindful of is early trend in weight gain. I will do this very quickly. So we already talked about this, that first year is a critical period. Weight gain can be very substantial and rapid in the first year. And this study published 2023 in September, very interesting study. I just want to spend some time on that. So this were like first episode psychosis patients who were admitted to hospital. 173 patient, they actually started them on antipsychotic and monitored their weight moving forward. In 45 days, they gained 3 plus minus 7 kilogram, a lot of weight. Now, the key here is this, friends. Please keep an eye on this here. They found greater antipsychotic exposure was associated with greater BMI increase, but only in people with normal or low baseline BMI. I don't know what to make of that. So this low BMI looks like, or normal, like they are also at risk. So we should not only keep an eye on high BMI patients, but that is something to be mindful of. The weight gain can be very quick. They are saying first year, I will say in first weeks, keep an eye on that. And this is a learning here. The most clinically significant factor that influences your long-term risk of adverse cardiometabolic outcome is change in weight and BMI in the first weeks. So very, very important. Even before adding medication, we already know it, but I think it's good to hear from somebody else as well. Have a baseline BMI and weight done so that you know what you are going after, not after you have started the medication and checking your patient in maybe 3 to 4 weeks and checking the weight again. No, by that time, the impact might have happened. And that is where we struggle sometimes when patients are discharged from inpatient unit. If weight is not done or we don't have that information, that is a struggle, but try your best to get it done before starting the medication because impact happens within first weeks. Now, this is interesting. The studies have found that there is some evidence that a person's eating behavior can predict risk of weight gain because this one study found that if a person has increase in appetite at week 4, it can have significantly greater weight gain in 3 months, 12 weeks. But these are just a potential predictor, so I'm not spending much time on that. They say eating behavior and raise in blood glucose. I will say go with HbA1c rather than just going for blood glucose. We'll talk about that in a minute. Moving forward. So we talked about predictors. We talked about parameters. Now let's spend some time on threshold. When do you feel it's okay to jump in by adding metformin? At what threshold can you do it? And I think this is another clinically relevant fact here. Based on the recent guidelines, the threshold for intervention is 3% increase in baseline body weight. So you have, this is for adults actually, for adults. You measure your weight and if it increases, crosses 3%, you add the medication. Now, not to complicate it, this is only for patients where you have not added metformin. Let's say your patient is on medium risk antipsychotic and low risk antipsychotic, and they are not less than 25-year age. They don't have any cardiometabolic risk factor, and you're just waiting. And you're measuring their weight. As soon as weight crosses 3% here, metformin needs to be added. And this is a table, example. Let's say somebody's 60 kilogram, 3% is even 1.8 kilogram, same goes. But for children, very important, it has to be in the first year. And this was actually based on the consensus of the professionals who met for these guidelines. And they found first year to be an important timeline stamp for us to be mindful of. But based on what we have learned so far, I don't think we even have to wait for first year to see it. If patient is at risk, you may see it sooner than first year. But they felt first year is a safe margin to keep an eye on that. But for children's friend, they say it's still 3%, but it is outside their expected trajectory of weight increase. Because children have different trajectory of weight increase for that reason. For anybody between age 9 to 18, you need to use the WHO growth charts. And that is what's mentioned here. Young person, 3% more weight gain outside your expected growth trajectory. And here is the recommendation, summary of what we just talked about. Add metformin with any antipsychotic if more than 3% increase in baseline body weight is seen in the first year of treatment. Now let's put everything together into that slide that I mentioned. So far we know this. High-risk antipsychotic, you don't even have to think, add metformin immediately. Medium risk, you only add if these factors are present. What about the other areas where these factors are not present? That's where you will use the 3% threshold margin for adults and for children's. Now, moving on. Let's talk about briefly, we are almost at the end, friends. I hope I'm not taking more time here, but we are almost there. So let's talk about what dose should be used for antipsychotic-induced weight gain prevention. So how can you dose this? The studies have found dose between 500 milligram to 2000 milligram per day to be effective. You need to use a weekly increase schedule per this recent publication, which we will talk about in a minute. And they said you need to increase the dose based on the BMI, weight, or increase in appetite, which is one of the factors we talked about, right? And ideally, you should take it with food because metformin have very common GI side effects. But you can use that slow release tablet once a day if GI side effect persist. But that can do constipation. And if GFR is between 30 to 45, max is 1000. Ideally, we should avoid it, but max is 1000 milligram per day in that. So the summary per this guideline is, first week, you do 500 milligram in the morning. Second week, you can go to 500 and 500. And then you wait for efficacy with BMI or increase in appetite and wait for 2 weeks. And you can even go to 1000 in the morning and 500 in the evening. And again, check for efficacy. And then after 2 weeks, I'm sorry, I'm sneezing. You can go to 1000 and 1000. When I saw this, it looked very aggressive approach in my opinion, but I don't want to assume from my side. Please let me know how you feel, like friends. Like, do you feel this is too fast? Is this how you do it? I mean, I do it personally very slowly. Maybe I'm doing slow. I don't know. We'll talk about that in a minute. Now, very quickly, when you add metformin, what monitoring is needed? Now, pre-treatment monitoring, before even you add it, let me see quickly. Pre-treatment, you need to check your GFR. The most important thing before even you add metformin. Obviously, you need to have BMI, weight, and everything done, but renal function is very, very important because less than 30 ml per minute, it's contraindicated. 30 to 45, initiation is mostly not recommended. But if it comes to 30 and 45 while you're doing, that's a different scenario, but before, ideally avoid it. Now, you have started it. Ongoing monitoring, you need to check BMI and weight. You need to look for lactic acidosis, which is a rare but serious side effect. You should look for dyspnea, like breathing difficulty, muscle cramps, abdominal pain, temperature dysregulation with hypothermia, and asthenia. There are many more, but this is something a person needs to be admitted, looks like very serious, can be life-threatening. Liver function ideally should be monitored annually, and HbA1c ideally should be done annually based on these guidelines, but you can do more frequently as well. Now, renal function, ideally annually, but every 6 months for high-risk patient, which is obviously elderly, somebody who is 75 years or more, or somebody who is on these medications which impacts kidney function like NSAIDs, or blood pressure medicine like ACE inhibitors, ARBs, or diuretics. Now, here's the thing. You're monitoring and you found that renal function is going down. Like, let's say it falls below 45. Then you need to assess the risk and benefit of continuing. But if it falls below 30, stop the metformin. Very important lesson here. And the last monitoring, very important one, is B12. Always order B12 when adding metformin, ideally annually, but you can do it every 6 monthly for high-risk patients like who are vegans, bariatric surgery, older adults again, on PPIs, which impacts absorption, and GI absorption issue. I'm not spending much time on this, but please post your questions if you have any questions on that. Now, almost at the end of this presentation, let's briefly talk about adverse event. So we have common adverse event and rare adverse events, right? The common one are, which are in less than 1 in 10, which is very common. The most common are GI one. Nausea, vomiting, diarrhea, abdominal pain, loss of appetite. They're transient though. If you stay consistent with food, it gets better. But immediate release, more likelihood of causing diarrhea. Slow release, more likelihood of causing constipation. So be mindful of that. Now, B12 deficiency is also a common one. So be mindful of, that's why we need to check B12 level. And then the second category is less than 1 in 100. Still common, but not this much common. And here we have taste disturbance. Very interesting. Some patients do report that. Now the rare one, which thankfully I have not seen personally, is lactic acidosis, liver abnormalities, and skin reaction. So be mindful of these. You need to know, look for these if a patient is complaining of that. Now, when should you avoid metformin? Avoid metformin if severe renal failure, mainly which is defined as GFR of less than 30, which we just talked about, hepatic insufficiency, acute metabolic acidosis, and this is really important, alcohol use disorder with audit score of more than 8, which increases the risk of lactic acidosis impact on kidney and liver. So be mindful of that. So ask for these questions when you're thinking of metformin. And when should you immediately stop the metformin? First is obviously if lactic acidosis is suspected, but there are other conditions which can increase the risk of lactic acidosis. I will just name them, so be mindful of them. Ideally, I don't even start metformin if any of these are present. Like patient with dehydration, like severe diarrhea, vomiting, fever, or reduced fluid intake. And many times, diarrhea can get intense with our medications like serotonergic medications. Even metformin can do that. And if it gets really intense, you need to be mindful, is the patient going into dehydration, thereby increasing the risk of lactic acidosis. We just talked about it, acute alcohol intoxication, or patient who is using excessive alcohol with audit score of more than 8. Decompensated heart failure, respiratory failure, recent MI, hypovolemic shock, and severe infection. And the other area where you need to stop metformin temporarily is if a patient is going to an investigation where iodinated contrast agent is needed. You stop the metformin, recheck the GFR in 2 days, 48 hours. If GFR is normal, you go and add metformin again. And obviously, if GFR drops below 30, I'm repeating this many times because this is, I think, really a red flag if GFR drops below 30. BMI is less than 30. Obviously, we don't want a patient lose more weight. Sick day rule. Stop if patient is not feeling well and restart when they are well. And the last is, obviously, if antipsychotic is stopped, you don't need it, stop the metformin. Now, the last point here is, when are GLP-1 agonists indicated? GLP-1 is such a big hot topic nowadays. Recently, you all know, like last year, Wegovy was approved to prevent life-threatening cardiovascular events in adults with cardiovascular disease and either obesity or overweight. And just now in December, the Zepbound got approved for obstructive sleep apnea. And just like few days ago, I believe it's 2-3 days ago, FDA approved Ozempic as the only GLP-1 to reduce the risk of worsening kidney disease and cardiovascular death in patients with type 2 diabetes and CKD. This makes such a big deal with what we have just talked about with the cardiometabolic risk factor. But I'm hoping as the more studies come into our antipsychotic-induced weight gain, these medicines may sound promising. They should sound promising, but we'll see how they pan out. Now, we have a lecture by Dr. Kaur in our academy where she went into more details of that. If you're an academy member, please go and check that. Now, GLP-1 agonists are indicated if BMI is 30 or more. But if BMI is between 27 to 30, you should consider if one of the following is present: hypertension, dyslipidemia, diabetes, prediabetes, and obstructive sleep apnea. It's approved for obstructive sleep apnea now. But these are all those cardiometabolic risk factors that we talked about recently, right? Now let's put everything in one slide. This is what we talked so far. This is what I just mentioned. If BMI is more than 30 or between 27 to 30 and one of the following, you add GLP-1. And if GLP-1 is not available, you add metformin. So friends, I hope this was beneficial. I just want to take 15 seconds to talk about our academy membership. Many of you are already our academy members, but if anybody is interested, please email me here at hsingh@psychiatryeducationforum.com. We have 470 plus chapters, journal club discussion, academy insight, where I go into recent publication so that you stay updated. Me and Dr. Kaur post some chapters on clinical case discussion. We have closed Facebook group, and you can get discounted CME access. But let me go back. So this is our presentation. I don't know, I think I took more than expected time. I hope this was beneficial.